Welcome to the Elevated Lead Care Coordination Protocol. There have been several changes made to the protocol since our last training on lead. The purpose of today's training is to train new staff coming in to work with children with elevated lead, as well as inform staff currently working in the lead program about the new changes to our protocol. Participants in today's video will learn testing methods for elevated blood levels, reporting requirements to the central office, new protocol requirements for care coordination services, and care coordination services to families to alleviate and prevent elevated lead. All care coordinators providing services to children with elevated lead levels must watch this video and complete the test available in the registration materials. We have with us today Sarisha Johnson, Program Director for the Alabama Childhood Lead Poisoning Prevention Program, to start off our training. Thanks, Sarisha, for joining us.
Yes, glad to be here. So before she gets into the protocol, I'm going to talk a little bit about the ins and outs of the lead program and particularly touch on some of the challenges that you encounter in your day-to-day case management with the elevated lead follow-up. So first of all, with lead, the way to find out if a child has lead poisoning is through blood lead testing. And there are two types of specimens that can be collected. You have capillary, and then you also have venous. Capillary is commonly what pediatricians and other pediatric providers will use for annual screening. In addition, according to CDC guidelines, it can also be used for confirmatory testing as long as it is completed within 12 weeks of the initial elevated results. But it is important that we impress upon providers that they should not be using it as a follow-up test for confirmed elevated blood lead levels. And that is because capillary testing can be easily contaminated by unclean skin surface and by other environmental contaminants that children can encounter both at home and in the office. Venous testing is considered the diagnostic test to determine if a child has blood lead levels that are elevated. And it's the one that we really should be encouraging as the more reliable confirmatory test method. It should be used for any follow-up that is done for a confirmed elevated blood lead level. In addition, it is one that cannot be done in the office. So where a lot of doctors do tend to do capillary testing, one, because it's less invasive, and secondly, because they have point-of-care testing they can do in the office, venous testing has to be analyzed by a reference laboratory. And some providers will collect in the office and then send it to a reference laboratory. Others will send an order with the family and send them actually to another lab to test it. And that is something that can also be a challenge because sometimes when you send a parent to a second location, it decreases the likelihood that this test will actually be completed. So for point-of-care equipment, we have a considerable number of providers in the state that use lead care 1 and 2 point-of-care testing systems. It is very important that this is never used for venous testing, and this goes back to a recall that occurred in 2017 as a result of false negative results for venous tests. And the link here will actually take you to the information there from FDA and Magellan themselves. Secondly, this system is limited in what it can report, so it can accurately report capillary results of 3.3 to 65 micrograms per deciliter. If it is less than 3.3, it simply will read as low, but providers should still be reporting that as a less than 3.3 result according to manufacturer instructions. If the equipment reads high, then that is a greater than 65, and it is a possible medical emergency, and that is where immediate venous follow-up should take place. The lead care equipment should not be used as follow-up for any confirmed results, and again, that goes back to we need to be doing venous testing once we have a confirmed elevated blood lead level to ensure that we are getting accurate results that have not been contaminated by any environmental sources. In addition, when we get our reports from you, it's important that we get certain pieces of information that help us to know what the next steps are for the child. And this goes into the day-to-day follow-up that we do from the lead program. So first of all, anytime a new lead result is received, we need to know what that lead result is, and we need to know what the collection date is, the blood source, and the blood lead results. And that can be a little confusing sometimes depending on how doctors' offices report those. You may get a numeric result. I have been told before that doctors just report it as low because they're using lead care, but again, they should be reporting that as a less than 3.3. And if they are doing the appropriate venous testing that we want them to do, then if we had for example, a false positive capillary, and then they do a venous test and there was no lead detected, instead of getting a numeric value, you may get a not detected or a none detected reported to you. In addition, we also need to know if there are any follow-up appointments made, if that is, applies to that situation, and any information regarding contact with the caregiver. So we're looking for information if you have had unsuccessful contact, if you've had a caregiver refuse the testing or even the care coordination services, and of course if everything goes the way we hope it will, any education that was provided, the home visit that was made, and the type of the materials you may have provided to the family. In addition, any other pertinent information that you come across we would want shared. So that could be contact information for a DHR worker. That could be issues with a provider not wanting to do the appropriate testing. It could run any gamut of things, but anything that affects appropriate follow-up for blood lead, we would want that shared with us when you provide the care coordination reports to us. So the difference between a capillary and a venous, with a capillary specimen, they just simply stick the finger, get a little bit of blood out of the finger, and they can either put it in a tube and send it to a lab that does capillary testing, or if they do have the point of care equipment in the office, then just a drop or two, they put it on the machine and it reads like, say, a glucose monitor or any other type of equipment where a few drops of blood can give you a blood lead level with the equipment. With a venous test, the blood does have to come out of a vein. Typically, it's going to be drawn out of the arm. And again, that is one that has to be analyzed through a reference laboratory and cannot be analyzed in an office. And so again, that is our gold standard for knowing whether blood lead levels are actually elevated or not.
Well, now that we've talked about testing, we're going to move on to care coordination protocol. When the child has had a capillary blood test and it's indicating that they have a lead level of 5 or greater, the care coordinator will contact the provider, the medical provider, and the family, advising them that they need a second test done, hopefully a venous test, because that is our gold standard. You will notice that this is a change in protocol. Previously, we only did this for lead levels of 10 or greater, but that has moved down to 5 or greater. At this point, there isn't a confirmed blood level. All we're doing is reminding them that they need to get that second test, and it's very important to do so to make sure this child actually has an elevated lead level. At this point, you don't need a psychosocial assessment, a case plan, or educating the family. That will wait until the blood lead level is confirmed. If a specimen is not collected within 1 month, the care coordinator will contact the family and the physician and remind them that a repeat specimen is required. Many of our families do not have phones. They're difficult to contact. And so in those cases, a letter should be mailed to the family to remind them of this. A report to the referring provider will be sent letting them know that the physician and the family have been informed. Now, when we talk about the report to referring provider, we're talking about the central office. We're talking about Sarisha and her program. So I'll be using this interchangeably of the central office and ACL PPP, which is the name of her program. So that referring provider is the ACL PPP. And you'll be letting her know that you have reminded the physician and the family that they've been informed to get a repeat specimen. Then another report will be sent once that repeat specimen has been collected and what the results are of that test. If a specimen isn't collected after 60 days, the care coordinator will send a report to the referring provider, which is the central office, indicating that the physician and the family have been notified, but no repeat specimen has been collected, and the reason why it wasn't collected. Cases will be closed, and the referring provider, which is the central office, will be notified of closure after 60 days of unsuccessful attempts to collect that repeat specimen. This is also a change in protocol. Previously, it was 30 days, but we have extended that to 60 days to give us more time to try to get that repeat specimen. On this slide, you will see the time frame for initial home visits. This is also a change because we don't start at 10 anymore. We start down at 5. So from 5 to 19 is within 2 weeks of referral, you need to be making that home visit. The higher the level of the lead, the greater the risk for the child. So as the lead levels go up, the sooner you need to get out there on the home visit. And that goes down to the bottom there, where if you have a 70 or greater, you have to be there within 24 hours of referral. Have you had a 70 or greater?
Thank goodness, no.
Thank goodness. I know when I was working out in an area, now called districts, we had some in the upper 20s and lower 30s, but I don't remember one being that high. How high is the one you've had?
The highest I have ever seen is a 49.
49. So that would be very unusual to have anything higher than that. But if you do, you've got to get out there right away. And then this is the tracking timeline to see when to get the repeat. And just like the home visit, the higher the lead level, the sooner you need to get it done. So once again, this is a change in protocol. We're not starting at 10, we're starting at 5. And 5 to 9, it has to be collected within 3 months, and so forth. 10 to 24 would be 1 to 3 months, and the higher it gets, the sooner it needs to be done. So if you had one greater than 45, which Seracious had at least one, you would have that repeat specimen as soon as possible. Environmental inspections are done on those children with lead levels that are 15 or greater. Prior to a referral to the environmentalist, the care coordinator will complete a home visit and fill out the form that is the Service Standards Environmental Investigation for Lead Hazards form. That's a mouthful, I know, and it's in your training information. But again, it's the Service Standards Environmental Investigation for Lead Hazards form. Once this form has been completed after your home visit, you will send that to the environmentalist. This form can also be used for children with a lead level less than 15 if you're not sure what the source is. This can help you find out what that is. But you would not be making that referral to the environmentalist because the elevated lead would be less than 15. Once the environmentalist has gone out and done their inspection, they will provide the care coordinator, ACL, PPP, and the family a letter explaining what the results are. Where is the source of the lead? Then the care coordinator will educate the family regarding the source of the lead and help them in eliminating the lead hazards as appropriate. Sometimes a physician will want an inspection done even though the elevated lead is less than 15, and that can be done. But what they will need to do is write a physician's order on a prescription pad and send that in to the health department. In addition to that, a care coordinator can also request an environmental inspection after a home visit for the same reason. They're not sure what that lead level is. So with supervision and supervisory approval, they will contact the ACL PPP and notify them. Well, let me back up. They need to contact the physician first and have them write a prescription, just like if the physician wanted this to be done. Then they would notify the ACL PPP that the physician's order is complete And you would fill out a different form than the one I mentioned earlier, and that is the Elevated Blood Lead Environmental Surveillance Form. Once again, that's a mouthful. So it's Elevated Blood Lead Environmental Surveillance Form, or the FHS 135. That's the way I like to think of it. And this is faxed into the ACL PPP. I often just call this the FHS 135. Once all of that has been done, then the care coordinator will contact the environmentalist to arrange for the inspection. So in summary of all of this, you have two forms, and both of these are in your training materials. There's a service standard for investigations of lead hazards form, which is completed before making a referral to the environmentalist if that elevated lead is greater than 15. The FHS 135 form is completed if the physician has asked for that inspection or the care coordinator has and gotten the physician's prescription, and that is sent in to the central office, letting them know that this referral is being made. Children with elevated lead levels can be seen with care coordination services through two different programs. First is the Patient First program, and you would code to Patient First Children, service area code 31. The other one is Lead in Kind, and this would be for any child who does not have Medicaid, and that would be coded to Child Health, service area code 30. Make sure you're coding this correctly. Every month I'm going in to find the Lead in Kind because we have found some revenue to bill for this through our maternal child health program. And with these, I'm finding that just out of habit, our care coordinators are coding to Patient First Children, service area code 31. And when that happens, and if it's after the 6th of the month, we have to take that money back from Medicaid. So that's a little extra work for you in doing so. So make sure that you are coding correctly, and those children who do not have Medicaid, make sure you're coding that to Child Health Service Area Code 30. So referrals are received from us at the central office through Saracia, ACL PPP, and those referrals go out to the district social work directors or managers who forward those referrals to the county care coordinators. We also get referrals, as we mentioned, from doctors or possibly labs or clinics. Then the local people, if you get those referrals, then you will need to notify the central office of those referrals. This part of the referral process is new to the protocol, so you'll need to pay particular attention to this. When a referral is received from a private provider, you are going to mark the referral form as a central office referral so that in order for the report to the referring provider to be received by the ACL PPP. So let me repeat that. You're going to need to mark that referral form as a central office referral in order for the report to referring provider to be transmitted to central office or Saracia staff. This report to the referring provider can be printed and faxed to the private provider if they want that. So it'll be transmitted to the central office, and then you can print it off and send it to that private provider if they have made that referral. Then you're going to mark the referred from a private provider on the reason tab for the referral, in addition to all the other relevant reasons on the referral form, such as elevated lead. This is a change in ACORN, and it went live July the 1st, so you should be able to find that. That way we know that the referral did come from the private provider, and we can track that. So once all of that is done and we've gotten the environmental inspection, the care coordination services are provided to the family and to the child. You're going to want to educate the patient and caregiver on the possible sources of lead, and we're going to go into some of those possible sources on the next slide. You want to help them understand the need to reduce lead exposure to reduce harmful effects in the child. Help them understand ways to reduce exposure, such as house cleaning, good hygiene, and nutritious diet. The need for continued testing is important to monitor the child's lead level. You can't just stop with that one lead level, and maybe the repeat doesn't bring it down enough. So it is important to help them understand the continued need for that testing. Help the parent to understand and know when to retest, and then educating the parent on the impacts of lead exposure on the development of the child and what to watch for, such as the milestones that they would anticipate, mental and physical developmental milestones that are slowed, and if the children are falling behind their peers of the same age. We're going to be going into more details on the effects on the child in a webinar that will be done next month in August about those details of how harmful the lead exposure is. So stay tuned for that. So what are some of the sources of child's exposure to lead? Well, one can be household lead dust, deteriorating lead paint, which can be found in the home or outside that is chipped off. It could be chipped off and into the home that results in that lead dust and stuff that can get into the carpet, or it can be on the porch. It can even get into the soil. It can be blown out into the yard and the children are playing in that soil and they can get lead that way. It can get into the water supply. Think Flint, Michigan and what all they went through. Or it could be in pipes in the family's house where that lead is coming from. Occupations and hobbies. Several years ago when I was a social work director up in Area 5, we got a referral on a lead, and it was our highest we had ever seen. It was that in the upper 20s and early 30s for their lead level. And it was 2 preschool children, and when the social worker went out there to check on it, the father, who was a mechanic, was actually bringing car engines into their trailer and working on car engines into that trailer. And so the lead levels there were unbelievably high, and it was impacting their preschoolers. So you never know what you're going to find when you get out in those homes and what that lead resource was. Who would have thought there'd be a car engine in a trailer? But there was. Use of foods, medicines, cosmetics produced abroad, and then household products such as cooking utensils, potteries, toys, and mini blinds. On pottery, a lot of people immigrate here to Alabama from Latin America and Mexico, and there's lead in their pottery in certain instances. Other families go on vacation to Mexico and Latin America and bring home pottery, and we have found lead sources to be in that pottery. And then old mini blinds can be a culprit of lead that the children are exposed to. So once you've educated them on that, you want to assess the family's need for ongoing education. How much did the family comprehend what you said? Sometimes we have to repeat what we say to families, and you as care coordinators totally understand that. How easy is it to eliminate the lead? Is there need for follow-up testing? On that case of the trailer, there was a lot of lead in that trailer, and it was going to take a lot to clean up. Unfortunately, they wanted to keep working on engines in their trailer, and so the children actually had to move out of that trailer and live with their grandparents. We got DHR involved, and they were removed from the home because they wanted to continue working on their car engines in the trailer. So you have to look at that and see, is that environment safe for that child, or is there something else you're going to need to do? Once you've assessed all of this, assessed the parent's understanding and how much needs to be eliminated, then you would develop a care plan. And the family, of course, would assist you in that care plan. Sometimes there's a lot of work to be done to clean up homes from lead. And what is that? What needs to be done? And then adding that to the care plan. You may find other interventions to address needs that are identified. Maybe they are having trouble with transportation. Maybe the children are behind on their immunizations. There's often additional needs, as you well know, and those would be placed in there if needed. Once the child has a consecutive test of under 5, the case may be closed, but you may have some unresolved issues. And so for those cases, you would refer to a patient-first care coordinator, or if you are a patient-first care coordinator, you would just continue seeing that child, or refer to the appropriate agency. Once the ACHNs are started, you would probably want to refer to them, or other appropriate agencies may be early intervention or our EHS program would all be appropriate. You may need to also involve DHR in these cases. And what I'm finding with DHR, some people are very aware of lead hazards while others are not. I have spent many an hour with a DHR worker on the phone explaining why it is so critical for the lead to be cleaned up in a house and the exposure of lead and the impact on children. And I've heard that from other managers, directors, and care coordinators as well. One example that we had recently in this state is that there was an elevated lead in a foster child. And so we had to determine, is it in the foster home? Is it in their home before that? So are there other foster children that are exposed to lead? Or is it their siblings from their home of origination before they went into foster care? It can get very complicated. So sometimes you will have to work very closely with DHR before you close out a case as well. After 1 year with no significant decrease in the lead level, case review is required. You'll want to talk with your social work manager or director, or call the central office, call the FHS social work director, which would be me. So you could call us and see what we need to do. Do we need to close the case, or do we need to continue it? If we decide to close the case at that point, then you would notify Suracia and the ACL PPP program of the closing of that case. You can also close the case for administrative reasons. Maybe you were unable to contact the family, but you would not close that case until you've made multiple attempts to contact the family. And you can contact them in several different ways. You can call the doctor's office, see what their contact information is. Some of these children may be on WIC. Use your local health department WIC clinic to see if you can find them. Maybe the mother comes in from time to time. So there are several ways that you can try to find the families. But if you cannot find them, that would be a reason for administrative case closure. Another one would be that attempts to assist are unsuccessful. Was the family willing to do something? Were they not willing? And then the case could be closed. But before you do that, you're going to want to look at the safety of those children. If there is noncompliance, you'll need to send a notice to the family, and this can be found in your protocol and document library as well. This is sent explaining to them that it is being closed for noncompliance and that their children are still at risk for lead exposure. And then determine if a DHR report needs to be made for medical neglect. You want to keep it open until all of that is taken care of and that you've followed up with DHR before closing that case. That ends the protocol section of this training, but I want to remind you that there is a test associated with this, and in order to satisfy those training requirements, you must complete this test and successfully pass it. Here is our contact information for Suracia and I. Thank you for viewing this video today, and I hope you have a nice day.